Dr. Taca, how are you today?
I'm very well, thank you.
Okay, we're rounding out our series. As you well know, the spectrum of substance abuse problems is as diverse as the number of shoe sizes in the earth. That's called human nature. So rather than struggle with trying to find something that fits everybody, that's what doctors do on an individual basis. However, we have seen common trends on some things that would cover a large group of people. So in terms of getting the community some help, that's why we wanted to round out your lectures.
Okay.
And we are very happy with the lectures that you have provided us so far. And just a little refresher for those who are seeing this video for the first time, we have a whole series on a device called the bridge. And we know the device called the bridge might be named several other things in the future. For right now, there is a device approved by the FDA that you had a significant role in intercepting, pardon me not being a doctor, intercepting the signals from the brain or whatever on pains of withdrawal. And again, what should I call that interception of that signal on the withdrawal?
Well, when someone is going through a withdrawal period from opioids, it's essentially a electrical thunderstorm in the brain. And too many signals are going to different places of the brain that are not supposed to be there. As a result, you have lots of multiple organ systems affected, causing what we see in typical withdrawal, which could be high heart rate, sweating, diarrhea, anxiety, muscle pains, all going on at the same time.
So in a way, it sounds like it's a two-way signal. The first signal is from the body that is expecting a daily dose or some frequency from the opioid, and that not coming sends a signal to the brain that causes this thunderstorm, and the brain sends all those signals back to the sweating, the agitation, and all the things that we commonly call withdrawal. So it's kind of like a crossing of signals.
Yeah, to make it easier to understand, there's inhibitory signals that may slow things down, and there are excitatory signals. And there should be a normal rhythm to this. When you take substances, in this instance opioids, if you take it for a long period of time, it suppresses the excitatory signals. If you do that for a long period of time and then you take the opioid away, all those excitatory signals come back in a big, again, produces this big tsunami of excitatory signals. And it's not supposed to be a full blast supply of this, and the inhibitory signals are too weak to suppress that, and we see that electrical thunderstorm particularly in the brain and organs distant from the brain, like the gut, the muscles, and things like that.
So all of those external symptoms, actually there's a scientific way of measuring that, and it's called, I believe, a COW score. And could you refresh us a little bit on what COW means?
So COWS is short for Clinical Opiate Withdrawal Scale. So it can identify the major symptoms and how bad one is going through withdrawal. For example, if you have a COW score of 20, that's probably high to moderate. And we can assume if you have a score of 20 that you're not feeling too well. The problem is when you're going through that type of withdrawal, it's one of the biggest triggers for somebody to relapse back onto opiates.
To blunt the pain.
To eliminate the withdrawal, you have to re-expose the brain and the body to more opiates.
And that's the endless cycle.
That's the cycle.
Now, question I have dying to ask you, in your experience, and you've got several years, what was your highest and lowest COW score?
Oh gosh.
If you can think of it.
Probably the highest ones would be more than 30. And we've treated people as low as single digits. The reason why we do that is we don't wait for them to come back and come in full blast withdrawal, because if we ask them to come back at a different time, we might lose them, and they may not come back, and they might continue to relapse. So if they come in with even mild symptoms of withdrawal, we initiate treatment.
I would like to note for anybody watching this video that we are in the beautiful city of St. Louis. You were so gracious on taking us around to the city today, and especially that beautiful basilica.
Oh, yeah.
What's the name of that church again?
It's called the New Cathedral, but it is the St. Louis Basilica.
Okay, it was beautiful.
Yeah.
But anyway, and we saw the Dred Scott decision courthouse, and we saw the train station. Just a wonderful city. I'm encouraging anybody, aside from opioids and whatnot, to go see St. Louis. But,
Don't forget the arch.
and don't forget the arch, yes. Although I will never go in that little cylinder up through there for several reasons we'll spare the listener. Having said that, though, I remember being in St. Louis. It may be the first time I ever got in my car to come to your office. And I remember a young man, we're going to obviously privacy issues, a young man coming from a farm clear down in deep south. He drove all day, him and his wife, and I remember you saying he had a cow score of about 28, and I had a brand new Apple Watch at that time. I don't know much about my Apple Watch except paging my cell phone, but at the same time, this is a newer version, but I remember looking at my Apple Watch after you put the bridge, it was called then, we don't know what it's going to be called in the future or whatever, but you put that device on this person, and within, I remember it was 3 minutes, his cow score was 2, and it was somewhere around 25, I believe.
Yeah, yep.
And so that's not an unusual occurrence.
No, not at all.
Okay.
I mean, think about it. These peripheral nerve stimulators, we access nerve bundles in the area of the face and the ear, and we're sending gentle electrical impulses through the ends of these nerve bundles that go directly into the brainstem. So electricity is almost instant. So if you think about all these uncontrolled electrical signals going crazy, and these devices interfering, you could have a rapid relief of symptoms within a few minutes.
And so having said that, going back to our first opening round of questions and answers here, the cow score is a measurement of that. Again, I'm going to say two-way signals. The first signal is it's now 24 hours or so since I had opioids, and my body is going to send you a signal. And that signal is going to hit the brain, and then the brain's going to have that explosion of signals go into all those parts of the body to physically demonstrate what the body is pouting about on not having opioids.
Correct.
Which normally causes them to do opioids.
Right. So
in this little bundle here of our information today, we have decided to coin that name, and I'm going to go on first. I'm going to keep people in suspense first. Do you believe in all your years of practicing that terrible moment, several hours experiencing that cow score and everything that goes with it, is probably the biggest barrier to having a person quit doing drugs?
No doubt. It is one of the biggest contributors to chronic relapsing is to get relief of that chronic pain. And so that's why people go back and using, they're not using opiates anymore to get a buzz or to get high. They're doing it just to avoid the withdrawal.
Okay, so having said that, we're basically looking at a situation where the greatest brochure ever with some young lady in a gauzy dress running through a wheat field of waving lilies and being happy and smiling, okay, or the image of somebody just kissing their loved ones, which are normally good feeling family photos and whatnot. Basically, that event or the fear of that event actually prevents that well-marketed treatment facility from ever getting that person to even show up, right?
That's correct, and we have identified part of the reason is the fear, and part of the brain that's involved in withdrawal is the amygdala. Amygdala is a part of the brain, deep part of the brain, that is involved in fear and anxiety. And that electrical thunderstorm that I talked about before, it's not only in the pain areas of the sensory areas of the brain, but it happens deep part of the brain, including the amygdala. So if you can think about, you have all these pain receptors being stimulated, causes all the pain. You have the amygdala on fire, and that causes more fear and more anxiety. So a combination of that produces this tremendous amount of distress that makes that person going through withdrawal only think about the next dose. So they're not thinking about rehab, they're not thinking about family or work.
Big picture issues,
no.
Completely out of their mind, because they know that painful several hours is blocking that.
And we've proven through a university-based study, we've done imaging on rats with the use of these stimulators, showing a reduction of amygdala firing for about 50%. So we know that the anxiety and the fear secondary to opiate withdrawal is being treated by these neurostimulators.
That withdrawal pain would probably last about 5 days, from what I've read, for the body to metabolize out the opioids, and then the withdrawal would end. Correct?
Yeah,
approximately.
Yeah, and people have to understand, the people who are watching this video, that it's not only the device. It's part of a patented process that really guarantees a chance to complete recovery. If you only use the device, you're going to be batting under the Mendoza line. But if you use the protocols and the method that includes medications, I mean, the device will carry most of the weight, but realistically, you have to address some of the symptoms through comfort medications.
Okay, so I'm going to walk backward from what you just said a little wee bit. So we're saying, before we get there, that those 5 days, generally speaking, almost always prevent anyone from getting help. So they'll trade the rest of their life to avoid those 5 days.
Mm-hmm.
Okay, having said that, this device interrupts those signals, and they do not feel the withdrawal pain.
That's right. And this is what we were talking. This we were talking about.
I just wanted to back up a little bit.
Yeah. So addiction, a big part of addiction is memory. So the brain remembers things that are pleasurable. That's why, we tend to repeat things that are pleasurable over and over again, and they remember the pain. When you're going through withdrawal, the memory is burnt onto that brainstem. And they will do anything to avoid the memory of pain. And so that's why the easiest way to get out of withdrawal is to use more. So that's how short-sighted that lizard brain is. It doesn't care about next week. It cares about how am I going to feel in the next hour.
And for 5 days.
For 5 days, yeah.
So having said that, the device can eliminate those 5 days, but after the 5th day, there's a whole lot more going on, and why that person would start again.
Yeah.
He may feel wonderful, but within days. So we know that there has to be a passing of the baton.
That's right.
Like in a relay race. And we just talked about that a little bit, and that's why we have to be ready before the expiration of that 5th day to hand off. And most often you believe that again, as varied as the number of shoe sizes on the face of the earth. However, large numbers of people, if blockaded, if they would relapse, then they would not respond to the relapse. And at the same time, now that's what we call medicine-assisted treatment, but at the same time, counseling is taking place and whatnot to basically get that blockade long-term.
You are correct. You
what
are
we
correct.
would call extended care. So I don't want to go into extended care, but I want to go back a little bit, though, to talk about that 5th day coming. That first day when that device is put on, it seems to me, I was really captivated by some of your colleagues on what they do. They don't just put that on and say, I'll see you in 5 days. You have some protocols that take place from the moment it's on.
Yeah. So,
and if you wanted to talk about that a little bit.
So the 5 days is actually the more chaotic part of treatment, because you're trying to make the person feel comfortable, not throwing up, preventing a hospitalization. But the hard work is really after detox. Because if you can imagine, when you're using drugs or opiates or drinking for a long period of time, the brain changes, right? There's upregulation of certain receptors, there's downregulation, your mood is up and down. When you detox somebody, all the opiates are gone. So you might think, I'm free of opiates, I'm doing good. But that brain is different. So there's a period where we call it a post-acute withdrawal syndrome, wherein you have signs of anxiety or depression. Even though you're clean of the substance, you might not be sleeping well. You might be complaining of more depression. It's after that 5th day, really, when the team has to really roll up their sleeves and determine what's really going on under the hood.
But even before that 5th day, though, the person generally doesn't come to you and have the bridge put on and say, I'll see you on Friday.
Correct.
You still need to see them even the very next day, I think. I can remember. So you pay a lot of attention to the person even after they put the bridge on.
Absolutely.
Correct?
Yeah, we're monitoring them.
In fact, you usually want them to stay in town if they're from out of town.
Yeah.
For how long? Well, 5 days?
The device usually is programmed for 5 days. In some instances, it's programmed for 10 days. But usually in 5 days, we capture most of those symptoms that they complain about.
So you don't ever put the bridge on and say, come back in 5 days?
No. We will send them home.
Or whatever it's called.
We will send them home, but we are monitoring them distantly or electronically through video, definitely making sure that all their vital signs are within normal ranges. If we can treat any other symptoms that are popping up, like let's say they're having a little bit more nausea that may require some medications for that, or some insomnia, we're right there to treat that immediately.
So in a large numbers of people could take the bridge, or whatever it's called. They would be monitored. They successfully arrive at the 5th day. The rest of the team is really gearing up, and eventually you get to a non-narcotic blockade, which would be like a naltrexone-based system.
Correct.
Or maybe an implant which lasts longer. And now they are no longer subject to the withdrawal. And every day that goes past, they get closer to a time where they're successfully moving on.
Correct.
Having said that, we decided that you, as you indicated, that the big battle then, the big dance, is the withdrawal elimination.
Correct.
And it's not more or less like an electronic withdrawal elimination from what you're describing it. In fact, this evolved into a current phrase that one of your associates and you have pioneered called withdrawal management. Withdrawal isn't just an event. It's a management of a series of events.
Right.
Condensed into a very short time frame, but critical to everything that happens in the rest of their life, probably.
Correct. Absolutely.
So having said that, we would call this video the withdrawal management explanation video.
Yeah.
Is there anything else you think we should add here before we transition into alcohol?
I think it's important that when you're doing withdrawal management that you have the right patient, the right level of commitment, and the right family support, because we may depend on family support or anybody who's taking care of the patient to implement some of these things. Because if you can imagine, somebody may be too sick to go to the to the pharmacy. So it's important that we have a kind of a teams put together so we can all get to the same.
And having said that, we just all arrived and converged on you 2 weeks from Christmas, and you were nice enough to give up your Saturday, and I know you don't have too many free Saturdays, and we just actually brought a person up who has a legal motivation. May not be something that's wonderful, but he's here because he needs to be, and his family support was very instrumental on pushing him into treatment the right way, with the right attitude. Without saying any names and whatnot, you and I will be able to watch this video years from now and know who and what we're talking about. And that team includes Dr. Opita here and Dante Ludovisi, and him filming these precious teaching moments yourself, myself, and the patient and his wife. And it could have worked any better today.
Yeah, I agree. I hope our plan for him will be an effective one.
Now, we're going to move on now, and our Dante will know now where to edit, and we're going to pick up where we left off, Doctor. We have a lot of video that you did for us at the country club, and we're not going to retrace our steps. And our company now has decided to put a little more emphasis back on alcohol. And I want to incorporate that discussion we had in the conference room. We have been working on the withdrawal management. We just went over that right now, and the blockade, total abstinence and whatnot. And all along the way, alcohol. And I keep thinking of the song, I can't remember who it was. The beat goes on, boom, 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 boom. The beat goes on with alcohol. And to me, it's so immense that it seems like people don't even talk about it anymore. They have given up on that. And they just basically accept it will always be with them.
Yeah.
Okay, so we decided to reach out and aggressively market on the DUI. And why do I using the word phrase DUI? Driving under the influence. I'm from Pennsylvania. I'm an attorney. I honestly don't know what they call it in Missouri.
It's the same DUI.
Yeah, and I know it's something. It's operating while intoxicated or something. That might be OVI in Ohio. I'm not sure. Whatever it is, it's illegal. So, having said that, we have an opportunity. The opportunity is that if somebody is facing criminal sanction, and it's pretty aggressive in alcohol, okay? If they're facing criminal sanction and the right doctor and the right attorney ethically collaborate, they can turn what appears to be a perfect storm into a perfect opportunity. A person who has a DUI proceeding coming up, or worse, multiples with a prior record, has a very serious legal problem. And that's if they have escaped killing someone or killing a family member or whatever. They have a very serious legal problem. At the same time, they have a very serious health problem. So if you think about it, that sounds like the worst problem you could ever have in your life would be a legal problem, actually a health problem, and a legal problem. At the same time, that really makes it a problem. However, a collaborating doctor and a collaborating lawyer can take the happenstance of that moment in time and let the legal deadlines that are coming create milestones for the doctor to have a real foothold on treating the underlying health problem.
Yeah.
So again, to use a phrase that Dante and I have used over the years, is the perfect storm can provide the perfect opportunity for the right professionals to really change both problems and use the health problem to drive a legal solution and vice versa.
Yeah.
Having said that, it's a lot different than our opioid problem, correct?
Correct. To your point, the opiate epidemic is the star of the show. Obviously, it's been in our lives the last 25 years. But at any given moment, alcohol kills more people there are about 30 million people in the United States right now struggling with alcohol use disorder. And more people die from alcohol-related illnesses, far more than the illicit drugs, cocaine, opiates, put together. And so it is an opportunity for good, effective treatment. It's out there. I mean, opiates have been around last 50 years, but alcohol has always been goes back to biblical times, right?
In the book of Proverbs.
That's right.
In fact, we were talking about St. Paul. Informally, St. Paul, in some of his writings, talks about priests should not be drunkards. At least 3 sections of his letter to the Colossians.
Right, right. And some people don't realize that the withdrawal secondary to alcohol is much more dangerous and much more deadly than the withdrawal from opiates. You can die, and people die all the time from stop drinking abruptly. That can lead to seizures, and a percentage of seizures can lead to immediate death.
So if we go now and take that step, that it is, and I want to make sure I capture this number again, how many people die yearly from alcohol? Approximately.
Probably 200 to 300,000 people will die from alcohol-related conditions, not only from motor vehicle accidents, but alcohol-related illnesses include cancers, liver failure. The number one cause of liver failure is alcoholism. Cardiovascular disease. I don't think there's a system that's not affected by alcohol.
And in fact, we have seen that people that we have managed withdrawal, blockaded, and moved on past the opioids, many of those start doing alcohol then.
That's correct, and vice versa.
So having said that, on the alcohol, it sounds to me like, and I'm not a doctor, I'm a lawyer, it sounds to me like taking somebody to my courthouse and telling the judge that he or she is not going to do this anymore, okay, is a lot harder to say, because it sounds to me from what you just said, it's a lot harder for that person to detox off alcohol.
It can be, and much more dangerous.
It's certainly more dangerous, right?
Absolutely.
So now, having said that, we are so proud that you're part of our group. You're the medical person and the dean of our medical associates and whatnot. But we're so proud to have you there. You are also very much experienced in detoxing somebody from alcohol, right?
Yeah, absolutely.
And generally speaking, what tools are there for detoxing somebody from alcohol?
The standard,
other than coming in your office.
The standard approach to detoxing somebody from alcohol is trying to protect the person from seizure episode. So the standard approach would be a group of medications called benzodiazepines. But along with that, there are anti-epileptic medications that are also used as adjunctive medications for that purpose as well. We know some medications that protect from seizure, things like gabapentin, also have a anti-craving effect. So somebody may be put on a medicine called gabapentin for seizure prevention, but may also continue it so it could protect them from a future relapse.
You said anti-what again?
Anti-epileptic. So it's an anti-seizure medication.
Okay.
Anti-epilepsy.
And it sounds like no matter what, there has to be close monitoring during that detoxing.
That's correct.
Sounds like that with person, would they have to be looked at daily?
Pretty much. In the beginning, especially to determine, the most important thing when somebody comes in for treatment is determining if they require or do they need immediate medications for that. So the person who came in today came in with a little high blood pressure, a little high heart rate. So I explained to him that he may be in early phases of alcohol withdrawal. So I explained to him that if he doesn't drink for the rest of the day, the blood pressure may get high enough to where he may show some physical signs, some sweating, some shaking, and he confirmed with me that he's had those in the past. And as a matter of fact, he's had seizures years ago from his attempts from cutting down. So I told him that we have to immediately treat that. Gave him a prescription for medications that'll address those symptoms.
And so, again, that's on a case-by-case basis, and that's another reason why we're so happy that you're part of our group, and we hope you remain there for as long as we're around. You're a licensed psychiatrist, too. As far as I know, generally speaking, psychiatrists can prescribe medication.
Correct.
And so that's
yes.
that gives you a leg up. Now, on the detoxing of the alcoholic, knowing what you know about the penalties in most of our states, somebody from the time they're pulled over until the time they actually are sentenced, that could last months. Sometimes 15, 18 is not unusual. But eventually, that person is going to significantly chance to go into prison for even a month or so, even what we consider like a light sentence. They're in probably severe discomfort, if not danger, because I don't know of any prisons who know how to detox an alcoholic.
Right, and sometimes it's difficult when they're in a situation where the legal system demands them to be sober on day one. It's a high bar to meet because people who are not treated may struggle with residual withdrawal and high cravings. So the good news is when we treat people who have struggles with alcohol and they're not in the legal system, our interventions may include medications to reduce the craving. Now, that sometimes may take a while. It might take several months for somebody to reduce the amount of alcohol, but eventually eliminate it, okay? The good news is there are medicines that are FDA approved for the cravings of alcohol.
So, in the world of probabilities, would we say that detoxing is more dangerous for alcohol? It doesn't have, as of right now, any type of a device.
Correct.
We were talking about in withdrawal management. But it sounded to me, and I want to make sure I got it right, that it's pretty promising that with the right doctor and the right amount of time, it can be done.
Absolutely.
And the cravings can be eliminated.
Absolutely, yes. And
but the worst thing to do is to say it has to happen from day one, whenever that is. Today I went to court. Tomorrow they took me out and put cuffs on me, and I will not have anything to drink right now.
Sometimes it's difficult. That's a high bar to meet in many people.
Well, if they're going to jail, that's the only bar they're going to.
Right. No, I understand.
No doctor is going to visit them in jail.
Yeah. But the best way to increase risk of long-term success is address all those issues, because realistically, the 65% of people coming out of a treatment center will relapse within 3 months. And a lot of times, those 3 months, people are feeling good, they got a sponsor, they got a therapist, but the cravings are not addressed. And so sometimes that pink cloud, that 3 months of feeling great, the cravings come back, and the relapse occurs.
So in your detox practice, you're going to be able to keep the cravings from happening.
Correct. So we try to prevent that early relapse. So with the medications that we have now that are FDA approved for alcohol use disorder, people tend to stay sober longer, and it gives us a better shot at long-term success.
We always talked about, and again in some of our videos, and Dr. Pete is sitting here next to me, basically we talked about this many times. During that blockade for the opiates, during that detox for the alcohol, along the way in that journey, when we can keep that impulse from happening and relapse, something wonderful happens. A person gets something they haven't had for a long time, a reputation. They start to feel good about who they are again, and they fight it back. Most people aren't alcoholics or addicts, and most people have other things that they're interested in their personality and their reputation. And now we have engaged the services of the most important ally in either addiction, and that's the actual patient defendant. We have empowered him to fight the fight with us, and it's off the charts on the potential success.
Yeah, no, I totally agree with that.
So to those young attorneys who are listening to me, who want to join our network, I have a real strong message that I just learned today for the first time. And I've been doing this a long time, 7 years as a prosecutor. I know that the defendant matriculates through the legal system with a preliminary arraignment, a preliminary hearing, a formal arraignment, the potential of pretrial omnibus motions, call to trial, entering a plea, and being sentenced spans several weeks, if not months. I now will take my practice in a totally different way when I have a DUI or alcohol-related offense. I am going to get them and take that time frame to have somebody like Dr. Taca get them ready to go zero when the judge puts them in jail, if that's where this ends. There's no reason why we shouldn't get them prepared for being separated from alcohol while the court is struggling with their Sixth Amendment rights. That is collaboration at its finest.
Yeah.
And that's why the legal and the medical profession can work so well together. And we will be teaching this in our CLE class coming up. Now, this takes us to a whole new important thing. I'm seeing it in record numbers now. Driving under the influence, marijuana, the gummies or the legalized. I have very strong opinions that I don't want to say too much in this video, but I believe a lot of states now, in the name of not looking like they're weak on crime or substance abuse, have created these medical statutes where they're saying it's okay if you have medical, and I'm going to say it right now, it's my personal opinion. I have no reason to say it's anybody else's opinion. My personal opinion is some of these legislators didn't have the courage to stop it and not allow it to become legal. So they dressed it up by creating a fiction that if there is medical reasons, then it's okay. And I can tell you as a defense attorney, there is a million roadblocks you can throw in front of a prosecutor on medical use in a DUI accident, marijuana. Skipping over that. That's for another day maybe in the legal division. But skipping over that, what words of wisdom do you have for us on that as it applies to what we just said about alcohol, if any?
Don't drive when you're smoking weed. That's simple. The problem is with marijuana. I mean, it might be helpful in some medical or psychiatric conditions, but we know the risks. We know the side effects. We know that I've hospitalized many patients for psychosis, increased anxiety, for delusions. We know that people who have a genetic predisposition to schizophrenia will turn on that schizophrenia gene earlier when exposed to marijuana versus it getting turned on naturally over time. There's a lot of risks, and it's not safe. I mean, you'll hear that it's safer than alcohol. Well, you can argue that there's no overdose event there, but it can damage the way you think, the way you feel. It can make you psychotic. It can permanently switch on that schizophrenia gene. As far as driving, the problem with marijuana is that there's always for heavy users, there's always going to be a level of marijuana in the blood. So, for example, if one gets pulled over and they haven't smoked for a week, they can do a blood test, and then they can say you've been smoking, and they could be charged for DWI when they haven't been smoking for a week. Okay,
we've seen cases that go back a month.
Yeah, for heavy users. So it's not clear. It's not as accurate as testing for alcohol or other driving while intoxicated.
What opinion you have, if any, you may not have time to do a study or anything, but on marijuana as it exists when somebody as old as me was in college, okay, in the 70s, and now I have heard that it's
Totally
off
different.
the charts.
Totally different. Totally different. Now we have, the marijuana, when you were in college, when I was in college, totally different. Sometimes it's 10, 20, 30 times as potent. We have different forms of marijuana. We have the wax form. We've got the, Delta 8. So the Delta 9 is the regular, marijuana form that you get from THC, but some scientists have changed the molecule to make it legal to be sold over the counter, but have the same effects. So the drug, I guess the scientists in the lab that are promoting these over the counter synthetic illicit drugs, including Delta 8, including kratom, including something called hydroxy 7. We're seeing a lot of them come to our practice, specifically for these synthetic compounds, and they're not illegal. They're available over the counter, and they have the same effects as marijuana. They can produce psychosis in the wrong brain. We've got people that we needed a detox from kratom and 7-hydroxy as if they're going through opiate withdrawal. So they're horrible.